So, as per Dr. Wallach's request, today it's going to be about celiac disease. And our learning objectives for today will be to review the clinical presentation and prevalence of celiac disease, identify genetic factors associated with it, learn the molecular mechanisms underlying Gluten effects on the intestinal mucosa in celiac disease, consider the relationship between celiac disease and other autoimmune disorders, and understand the approach to diagnosis, management, and clinical outcomes. So when Dr. Rabinowitz and I were in training and we saw a child like this, we'd probably think this child had cystic fibrosis because, again, the intestinal presentation of CF and celiac disease is very similar. The wasted buttocks especially, the asthenic appearance, the bloated stomach, all suggests, obviously, malnutrition as a consequence, in this case, of a malabsorption syndrome. And indeed, in the middle part of the 20th century, before we knew about celiac disease, these children, especially in the UK, that had particularly, and still does have a particularly high prevalence of celiac disease, which actually, the celiac disease prevalence in the UK is actually the highest in Ireland for some reason. This is a picture of children in a celiac center. Now, celiac at the time was not defined as gluten enteropathy. It was just based upon the appearance of the children. I'm probably from Latin or some other language, and they were termed celiac, which covered a wide variety of illnesses. So what is celiac disease? It's an immune-mediated enteropathy caused by a permanent sensitivity to gluten in genetically susceptible individuals. It's a lifelong disorder. It usually presents in childhood, although 20% of cases present in adults over the age of 60. It is genetically determined and is particularly associated with HLA alleles, although these alleles are permissive, but they're not determinative for the celiac situation. So that the HLA subtypes that are associated with celiac disease are HLA-DQ2, which is basically 98% of the patients that we would see, and HLA-DQ8. If one is HLA-DQ2 or HLA-DQ8, one has the potential for having celiac disease, although the very presence is not diagnostic, since 15 to 20% of the normal population also manifests these HLA alleles. On the other hand, if you are not HLA-DQ2 or HLA-DQ8 positive, you cannot have celiac disease. So it's genetically determined in association with environmental factors, and obviously there are other genetic factors which we at this point are not, we don't have the knowledge about. The incidence is certainly greater than was thought 20, 25 years ago, and the characteristic finding histopathologically is the presence of abnormal small bowel villus architecture. The bad actor in celiac disease is, of course, gluten. Gluten is a protein derived from wheat flour. It's a group of about 40 different proteins and also found in rye and barley. Gliadin, which is the final common pathway leading to celiac, is the alcohol-soluble portion of the gluten protein. We can define patients with celiac disease into three basic groups. Those who we term the symptomatic, they're the tip of the iceberg. The silent celiac disease, that's right under the surface, and then deep in the depths of the ocean are the latent celiacs. Well, the symptomatic celiac disease actually comprise a relatively small portion of the overall celiac population. These are individuals who present with a wide variety of problems, including weight loss, short stature, primary amenorrhea, and other endocrine-like problems that may be associated with celiac disease and with other conditions as well. These patients, of course, will have abnormal intestinal mucosa. Then there are the silent celiacs. This is the group of patients that if you biopsy them, you would find that their abnormal mucosa is also present in the same way that patients with symptomatic celiac disease manifest. And of course, the silent celiac patient will also have the positive serologies, which we'll go over later on. And then there's the latent celiac disease patients. These are patients who have a positive serology. They have a genetic susceptibility because they're DQ2 or DQ8 positive, but their mucosa is normal. So we would define these patients as potential celiacs. And the question is, if you have normal mucosa with a positive serology, should you be on a gluten-free diet or should you just be followed longitudinally to see if something develops? Well, clearly that's an unanswered question, but we'll talk more about that as the lecture proceeds. So here are the asymptomatic patients, and they're the silent celiacs and the latent celiacs. They have no or minimal symptoms. They have a damaged mucosa in the silent case and a positive serology. They're identified generally by screening asymptomatic individuals from high-risk groups, first-degree relatives, patients with trisomy 21 who are particularly susceptible to celiac, and patients with associated autoimmune disorders such as diabetes. And we'll say more about diabetes and celiac disease a bit later. The latent celiac, as I mentioned earlier, have no symptoms and have normal mucosa. They are genetically susceptible because they're DQ2 or DQ8 positive. They may show a positive serology, which is identified by following asymptomatic individuals previously identified at screening from groups at risk. It is supposed that these individuals, given the right circumstances, it could be an intercurrent illness or something else which alters the intestinal barrier. So these individuals, under the right circumstances, may develop mucosal or will develop mucosal changes at some point. So where do we find these minds of silent or latent celiacs? And it's shown in this slide. First and foremost, it's first-degree relatives of the proband. And then we look at groups of patients who have potentially celiac disease based on their symptoms: short stature, unexplained anemia, fatigue, patients with hypertransaminasemia where there's no other obvious cause. And then, of course, there's the group that has associated diseases. This includes a wide variety of both autoimmune and endocrine disorders and can include patients with infertility. It's a favorite board question. A young woman presents at 15 years of age with primary amenorrhea. When you see that on the boards, you know they're looking for celiac disease because they always are. It appears just about every year on the boards. Patients with unexplained osteoporosis and patients with unexplained neuropathies. Again, the neuropathies, the osteoporosis, are a consequence of disordered vitamin homeostasis. And then finally, in large screening studies, looking at blood donors, students that are being screened, and the general population. Alessio Fasano, up in Boston, has done most of the work on defining the prevalence of celiac disease in the general population. So here we have 13,000 individuals screened, including 4,000 about to the left in the yellow rectangles who are healthy individuals, and those in risk groups. So let's look at the risk groups first. They include symptomatic patients, first-degree relatives, and second-degree relatives. Of those patients, the prevalence in symptomatic subjects is 1 in 40. In patients who are first-degree relatives, 1 in 22, and in secondary relatives, 1 in 39. Going over to the healthy individuals, there are 4,000 screened, 31 had positive serologies, 4,000 had negative, so the prevalence here is estimated to be 1 in 133. Now, this is all based on serology. It's not based on biopsy, so there may be some variability in the statistics. But overall, these data suggest that the projected number of celiacs in the US is over 2 million. At the time this study was done, in the early 2000s, the known celiac population in the US was 40,000. Doing the math, it was estimated that for each known celiac, there were 53 undiagnosed patients. This is why, for the fellows, when in doubt, screen, because the prevalence of celiac disease is far greater than we would suspect just on the basis of looking at symptomatic patients. So we talked a little bit about the pathogenesis, particularly as involved HLA typing. So it involves genes, here HLA and non-HLA genes. Gluten obviously is required. You can't have the expression of the disease either serologically or histopathologically unless you're exposed to gluten. And what happens? Well, we know that the infant gut is more permeable. It would be a consequence of regular infant feeding practices. Intercurrent infections that affect intestinal permeability, other things that could affect the immune system. This results in immune activation in at-risk patients, and finally, the expression of celiac disease. I can't reiterate too much. We've seen this before. In the absence of gluten in the diet, one cannot express celiac disease. One may have it latently, but unless you are exposed to gluten, you will not become symptomatic, you will not have a positive serology, you will not have a positive biopsy. So gluten, or gliadin, again, as I showed you earlier, is a part of if we look at the phylogeny, it's called the grass family, which includes a number of grains. And you see the only ones that contain gluten are wheat, rye, and barley. Neither wild rice, which is not really rice, oat, millet, teff, buckwheat. Buckwheat is not wheat. Buckwheat does not contain gluten. The problem here, of course, is when you have a grain that's processed in a plant where gluten-containing grains are also processed, you have cross-contamination. But the absence of wheat, rye, and barley in the diet effectively removes all sources of gluten. So, as I hinted earlier, several genes have to be involved in the syndrome. The most consistent genetic component depends on the presence of the HLA-DQ2 and/or DQ8 genes. Other genes that have not yet been identified account for what is estimated to be 60% of the inherited component of the disease. So again, to emphasize yet again, HLA-DQ2 and/or DQ8 are necessary but not sufficient for the development of the disease. And so when we look at HLA typing, when you have concordance in HLA identical SIBs, the concordance of having celiac disease is only about 50%. However, in monozygotic twins, the concordance is 100%. The risk in first-degree relatives is up to 25%, as I showed you earlier. And remember, when studies are done in Europe, 25% of non-celiacs have either DQ2 or DQ8 positivity. Again, so non-HLA genetic factors play a significant role. So let's move on to the pathogenesis, and let's look at the mechanisms for the failure of gliadin tolerance, whether gluten or gliadin exert a direct effect on the mucosa, how are T cell responses induced and maintained? What is the role of intraepithelial lymphocytes, and what is the role of autoantibodies? So for the fellows and students who are listening to this, these are all areas of study that you should be familiar with. These are all areas of study which you will be asked to comment on or answer questions on the boards. So when the lecture is finished, if you go and look at these 5 categories, you will know anything you need to know to pass the celiac disease board questions. Celiac disease, after all, is a disorder of receptor-mediated lymphocyte activation. It requires genes that are HLA or non-HLA that in some way code for the production under the right environmental circumstances of autoantibodies, of the development of specific T cell responses, which lead to the pathognomonic, histopathologic, and symptomatic characteristics of the disease. This cartoon shows how this all happens. Going from left to right, gluten in the gut is degraded to give a resistant fragment. This is a fragment that's resistant to intraluminal hydrolysis. This gluten fragment enters the gut tissue. How does it do that? It does that via paracellular uptake. And this would also involve the opening of tight junctions. So if you're going to do that, there has to be some predisposing factor that allows the uptake of this fragment via the paracellular pathway. So this gluten fragment enters the gut tissue and is deamidated by an enzyme called transglutaminase, which is present in the mucosa. When this happens, naive CD4 T cells respond to these deamidated peptides linked to transglutaminase. And this then is identified as foreign, leading to inflammatory effector T cells, which then attack the mucosa itself in an autoimmune fashion, resulting in mucosal destruction. So these T cells help autoreactive B cells as well that see transglutaminase coupled to the gluten peptide, and antibodies are formed. And these antibodies to transglutaminase, normally they wouldn't be produced, but when they're linked to this deamidated peptide, all of a sudden they're viewed as foreign, and antibodies are produced, and these are then diagnostic of celiac disease. The whole subject of paracellular uptake and how this happens in celiac disease involves something called the zonulin hypothesis. If one wants to read about it, and it's worth reading, again, go back to Alessio's work in Lancet, talking about how the zonulin hypothesis leads to an increase in gut permeability. Zonulin is a human protein involved in the regulation of intestinal permeability across tight junctions. The mammalian analog of Zonula occludens toxin, it is the mammalian analog of Zonula occludens toxin, which is secreted by cholera. So zonulin is really related to a toxic peptide produced by the cholera organism. So this, and I'll take you through this, is Dr. Fasano's version of what happens. So zonulin, sorry about that. I have a very sensitive computer. Zonulin interacts with a specific surface receptor and activates phospholipase C, it's number 2, that hydrolyzes phosphatidylinositol. Remember, we talked about previously phosphatidylinositol that is involved in intracellular signal transduction. So phosphatidylinositol that's hydrolyzed releases triinositol phosphate, triphosphate inositol, and diacylglycerol in 4. This then is activated via diacylglycerol or through the release of intracellular calcium. And then further on, we have the catalytic metabolism of individual proteins. Eventually, this causes actin molecules to be rearranged and displaces the tight junction protein ZOT1, ZO1 here, from their junctional complex. As a result, the tight junctions are loose. So here again, zonulin interacts with a specific surface receptor and through a variety of metabolic circumstances ends up with the opening of the tight junction. And that's how this fragment of gluten is able to enter the mucosa and the submucosa. Under normal conditions, these tight junctions don't open unless there's a selective flow of nutrients into the blood. But gluten mediates a disrupted barrier function between the enterocytes. So here we have gliadin from wheat gluten, and gliadin binds to a specific receptor on the cell surface. This is the CXCR3, and it has the long name down here. But suffice it to say, it's the CXCR3 receptor. This results in zonulin widening the tight junctions, which permits a non-selective flow of nutrients and other molecules into the blood. Then, based upon how our immune system reacts to this non-selective flow of nutrients, immune cells, cytokines, and other inflammatory cells cause its destruction of the mucosa and the resultant symptomatic disease. So this CXCR3 receptor is required in order for gluten to exert the opening of the tight junctions. To the left, we're looking at epithelial resistance. If we look at the wild type, control is in the open squares, and the addition of gliadin is in the closed squares. So for the wild type, what happens? All right, not much change in epithelial resistance. But when you add gliadin, and this is not a celiac patient, this is a normal experimental condition in normal explants. You see, under gliadin conditions, exposure to gliadin, epithelial resistance drops dramatically. When epithelial resistance drops, that signals the likelihood that you can have a non-selective uptake of molecules via the paracellular pathway. But what in an experimental group, if you look at CXCR3 negative situation, when you are CXCR3 negative, there's the open circles and the closed circles, which is right here. There's no change in the epithelial resistance. So CXCR3 is required as the receptor for gliadin. And here we have, looking at zonulin concentration, again in the wild type, you add gliadin, a marked increase. In CXCR3 explants, you find that there's no change. So CXCR3 is critical. It is the receptor for gliadin. Without the expression of CXCR3, ostensibly, one cannot have celiac disease. So again, CXCR3 is the target receptor for gliadin, and this CXCR3 gliadin interaction is crucial for the release of zonulin, leading to increased permeability. So overall, let's review everything we've just discussed. Gliadin absorption is via receptor mediation with CXCR3 through an open tight junction. As a result, we get the deamidated gliadin, and tissue transglutaminase modifies the gliadin into a substrate that can be picked up by an antigen-presenting cell. We have gliadin presentation to the TH cells via HLA DQ2 and or DQ8. This results in the Th1 cytokines being stimulated in CD8 positive T cells and NK cells. Th2 cytokines stimulate B cells into antibody secreting plasma cells. So the Th2 cells are producing the tissue transglutaminase. The Th1 cells are stimulating CD8 positive T cells. These CD8 cells are the intraepithelial lymphocytes that you see in the mucosa of patients with celiac disease, as well as natural killer cells. And it's these CD8 positive T cells, natural killer cells, that actually primarily destroy the intestinal mucosa. And just an interesting sidelight to look at the relationship with other diseases. This is a study done some years ago looking at the role of intestinal tight junction modulator zonulin in the pathogenesis of type 1 diabetes in diabetic-prone rats. When you have a zonulin inhibitor, the prevalence of diabetes in these rats is somewhere around 20-25%. But in control, it's 80%. So just by inhibiting zonulin, in the case of diabetes, you're preventing the uptake of macromolecules, leading to development of the disorder. This should lead one to understand that celiac disease it belongs to a family of diseases occurring in families. These primarily involve type 1 diabetes, celiac disease, and Addison's disease. So here again, to sort of bring that point home a little greater, is to look at HLA-associated risk factors for autoimmune disease. The most common association, of course, is celiac disease and diabetes. In fact, the HLA susceptibility is exactly the same. They're just reversed. In celiac disease, DQ2 is much more common than DQ8. In diabetes, DQ8 is much more common than DQ2. And the frequency of DQ2 and or DQ8 is greater than 95%, I would say really 100% in celiac disease, and 80% in diabetes. And this compares to the overall prevalence in the control population. So the relative risk is estimated at 30-fold for celiac disease and 14-fold for diabetes if either of these two genes is expressed. So how was this association finally made? Well, it goes back to the mid-20th century, where Thompson noted an increased incidence of diabetes in relatives of celiac patients. Between 62 and 69, the coexistence of these conditions were reported in a number of countries. And in fact, if you see a patient with type 1 diabetes in all diabetic clinics, they are screened for celiac disease because the prevalence among diabetics is about 10%. In celiac disease, we have DQ2 and DQ8, associated environmental factors, gluten, and celiac disease. In diabetes, we have the same genes as susceptibility factors, certainly environmental factors. What we don't know in diabetes is what's the final common pathway. What is the protein, if there is one, that ultimately leads to a cascade of events leading to the expression of the disease? So, if you screen patients with diabetes, up to 16% will have celiac disease. And there's a wide variability depending upon the clinic that one is looking at. And that's greater than 5 times the frequency in the general population. If you screen patients with celiac disease, 10% or 3 to 23% will have antibodies that are related to diabetes, but the presence at screening of the disorder itself is only about 2%. So, given those facts, of course, one wonders, it's the chicken versus the egg. In the patients who have these autoimmune diseases, what comes first, the celiac disease or the diabetes? When the two conditions coexist, the diagnosis of diabetes is almost always made first, at least in 75% of cases. However, celiac antibodies are often present at the time of diabetes diagnosis. So again, this asks the question of, if you have a patient with celiac disease and they may be at risk for diabetes, can diabetes be prevented? In patients with celiac disease, the chance of developing diabetes correlates to the duration of exposure to gluten. So the patients who are diagnosed with celiac disease first, after 2 years, only 0.8% of them are found to have diabetes, whereas if they're exposed to gluten for 10 years, that prevalence goes up to 7%. A gluten-free diet has been shown to decrease diabetes mellitus related antibodies in patients with celiac disease. So here we have subjects with celiac disease. 11% have diabetes-associated antibodies positive, 90% negative. 2 years on a gluten-free diet, 0% had antibody positive, 100% had diabetes antibody negative. Let's look at diabetes mellitus in first-degree relatives and those with positive diabetes antibodies. Let's put them for 6 months on a gluten-free diet. There was no decrease in diabetes-related antibodies, but 86% of them manifested increased insulin secretion. 6 more months after 6 months on a gluten-containing diet, there was no increase in antibodies, but 77% had a reduction in insulin secretion. So clearly, these two disorders are closely linked. And again, when you see a patient with celiac disease, obviously they should be screened in the most basic way, including a hemoglobin A1C level, of course, a fasting serum glucose, to see if they might be at risk. And even more important is to screen patients with diabetes for the possibility of celiac disease. Well, as I alluded to much earlier, the clinical presentation may be highly variable and can occur from infancy up to adulthood. The ages of 1 to 5 years are the most common, and that's not hard to figure out since gluten is generally not introduced into the diet until late in the first year of life. These patients may have obvious signs of malabsorption manifested by failure to thrive, malodorous, foul-smelling, floating, greasy stools. Dr. Rabinowitz and I have seen many of these kids, and I'm sure Dr. Wallach and Dr. Levine will attest to it. I find that the most common clinical finding in these certainly in the toddler age group, is these children are extraordinarily irritable. They're the child you want to give back. They may have anorexia, but they're just really hard to handle, incredible irritability. And in fact, when they're put on a gluten-free diet, generally within a week, their behavior changes dramatically. They may have a distended abdomen, buttocks wasting that I showed you earlier. Older children and adolescents and adults often lack the typical features. And one of the things, and I think Dr. Wallach could comment on this, is that studies have shown that some patients presenting with irritable bowel syndrome, particularly diarrhea predominant IBS, actually have celiac disease. So when your patients with IBS, this is another diagnosis which needs to be considered. The natural history of the disease is certainly one that should be obvious at this point. You have a genetically predisposed subject, all right? You have the environmental triggers. They have to have gluten. Something has to happen to alter intestinal permeability, which could include infections. Pregnancy itself increases paracellular uptake, or patients with other disorders. This leads to the development of celiac enteropathy. Now, once you develop celiac enteropathy, that does not mean you express the disease clinically. You can be silent, persistently silent, and remain persistently silent. Or at any point, you can develop clinically overt celiac disease and its associated complications. The endocrine features, short stature, pubertal delay, and again, I highlighted because it's always on the boards, primary or secondary amenorrhea, which includes primary or secondary infertility, and osteoporosis. When everyone sees this on a board question, look for celiac disease because that's usually going to be the answer. They may develop a macrocytic anemia because of folate deficiency and possibly B12 deficiency. Now, of these two disorders, folate may be more common because celiac tends to be worse more proximally, so that patients were more likely to express folate deficiency because of the proximal predilection for the enteropathy. They may develop, again, for the same reason, iron deficiency. So the anemia in these patients is generally of a mixed type. And because of problems with fat-soluble vitamin absorption, they may have elevated coagulation profiles. The neuropsychiatric features, again, certainly in children, they develop a profound irritability, but a whole host of problems, often related, again, to vitamin deficiency, may result in patients with the disease. So, how do we work these patients up? Well, certainly, do they have evidence of malabsorption? Well, you may find that many of your patients do not. What about their anthropometrics? You know, are they weight for height appropriate? Are they height for age appropriate? Again, in a symptomatic patient, depending how long they've been symptomatic, could there be an infectious cause? And of course, when in doubt, or even when not in doubt, it just as the regular course of events, looking at a wide variety of symptoms, doing serological tests is always a good idea. And of course, that finally, the gold standard is going to be the biopsy. If we look at the serological test comparison, again, when Dr. Rabinowitz and I were training, when we first started looking at this, the only thing we had was anti-gliadin antibodies, IgG and IgA. These had sensitivity and specificity and still do. I do not recommend getting anti-gliadin antibodies, except in unique cases. Far more sensitive and specific are the anti-endomysial antibody and the TTG antibody. Both of these can be expressed both as IgA and IgG, although we first look at the IgA antibodies, where the sensitivity and specificity of these antibodies approaches 100%. Tissue transglutaminase antibody is now the primary screen. Anti-gliadin, IgG, and IgA are clearly secondary. And again, tissue transglutaminase, anti-TTG, has a close to 100% specificity and sensitivity. Those patients who are IgA deficient may give you false negatives, which is why you can look at the IgG variant of the antibody. And again, the last thing you want to do is do these serological tests on a patient who's on a gluten-free diet. They have to be taking gluten because even in a patient with celiac disease, a period off of gluten will result in a normalization of antibody levels. So,
I hope I don't echo too much. I recently saw a 5-year-old who I sent had a strongly positive deamidated gliadin IgA and a negative TTG IgA. And there is a fair amount of controversy about what to do with that.
Yeah, that is.
Two, the celiac organization says that's celiac.
Yeah, well, you know,
so
we don't, you know, the deamidated gliadin is something that's come about in the last few years. And as Dr. Rabinowitz mentioned, there's still a lot of controversy. So can I have a student or a fellow read this case and provide me with an answer? I can't see who's on.
Yeah, it's hard to read. I can try.
Okay.
A 12-year-old male present to our office. Yeah, it's better now. A 12-year-old male present to your office for evaluation of abnormal celiac serology. He was diagnosed with type 1 diabetes approximately 3 months ago. He does not report any nausea, vomiting, or abdominal pain. He has normal daily bowel movement. He's otherwise for both height and weight. There is no family history of celiac disease. His recent laboratory tests include hemoglobin 14, albumin 4.2, ALT 32, AST 34, total IgA 70, tissue transglutaminase. It's 40, HB1AC 8.5. Of the following, the test that would be most helpful in the evaluation of the patient for celiac disease is endomysial IgA, human leukocyte antigen, tissue transglutaminase, dehydrated gliadin peptide IgA, none of the above. So the most helpful would be
Give me a guess.
endomysial A.
Okay. You gave me the answer I hope you would give me, because it's not the answer. The answer is
All
none
right.
of the above, right? And I'm going to show you in the next slide, and I don't expect you to know that, why it's none of the above. And this really is a result of the work that's been done by the European Society of Pediatric Gastroenterology and Nutrition. So this is a child or adolescent with symptoms suggestive of celiac disease. They had an anti-transglutaminase IgA and a total IgA. Let's look to the right. Anti-transglutaminase negative, not celiac disease. Consider further diagnosing if they're IgA deficient. Okay? All right. Let's put that away. Now let's look at the anti-transglutaminase positive. All right? The pediatric gastroenterologist discusses with the family 2 diagnostic pathways and consequences. All right? All right? If the positive anti-transglutaminase is greater than 10 times normal, they recommend an anti-endomysial antibody and HLA typing. If the endomysial antibody is positive and they're HLA positive, they have celiac disease, they put them on a gluten-free diet. If it's positive and they're HLA negative, consider a false test. Anti-endomysial antibody negative and HLA negative, false positive transglutaminase. All right? But the key here is patients who are anti-transglutaminase at greater than 10 times the upper limit of normal, you get an anti-endomysial antibody. If it's positive, in a follow-up for this guideline, if the anti-endomysial is positive and the patient has a TTG level greater than 10 times the upper limit of normal, that patient has celiac disease and you may not require a biopsy, nor would you require HLA typing. Okay? But if the patient is TTG less than 10 times the upper limit of normal, go right to a biopsy. So in this case, the transglutaminase was only 40, which is, right, 2 times the upper limit of normal. In this case, getting an anti-endomysial antibody would not prevent you from having to go for a biopsy. So the answer here, I said none of the above, would be small intestinal biopsy. So to review again, the follow-up of that study, if the celiac disease serology is positive for any reason, should be seen by a pediatric GI specialist. TTG positive, Consider how much it is above the upper limit of normal. If the TTG is greater than or equal to 10 times the upper limit of normal, get an anti-mesial antibody. If the anti-mesial antibody is positive, celiac disease is confirmed, no biopsy. If the TTG is less than the upper limit, 10 times the upper limit of normal, go right to biopsy. And that clearly is what we should be doing now, although I would suspect in the future things may change, and they probably will change to lowering that greater than 10 times the upper limit of normal being required. Well, how does celiac disease look? Here's a normal duodenum. And this is a typical finding. This is the capillary network at the base of the villus. Why do you see it? Because there ain't no villus to look at. This is a patient who has villus atrophy, allowing us to review the capillary network. And here again, you view the capillary network, and also you can see a slight scalloping shown better here of the valves here. This again is a characteristic finding. And you should all be familiar with the Marsh classification, which goes from normal to total villus atrophy. Of course, the most difficult one to come to grips with is the one where you have a patient who only has intraepithelial lymphocytosis, but the villi are obviously normal. This becomes very important in a patient where you find intraepithelial lymphocytosis in a patient who you haven't evaluated for celiac disease. Once you see this, you've got to make sure that the patient is celiac antibody negative. So in the old days, the diagnostic criteria, again, reported by the Europeans, small bowel biopsy, response to diet, histologic response to diet, clinical relapse with repeat exposure. So we used to, again, when Dr. Binowitz and I were in training, we used to end up biopsying some of these patients 2 or 3 times. Now, serology really replaces histology, except in unique circumstances. You know if a celiac patient is adhering to a gluten-free diet and is responding if their TTG and or EMA levels return to normal. And if you look on the bulletin board, we see all the time, well, I have a patient with celiac disease whose TTG is still hovering around 30 to 40 and they're asymptomatic. What do I do? And the controversy is always let it go and follow or rebiopsy. And I don't think anybody has come up with a clear answer. What we do know is that treatment involves strict adherence to a gluten-free diet, which in the past was expensive, difficult, and restricting. It is much less so today when any food store or anyone you walk into, I think, will have a large gluten-free section. And the ability to produce gluten-free products of a wide variety has increased dramatically. This is particularly socially inconvenient for children that go to parties, they have parties at school, other kids' houses, and it can be very difficult to make sure they adhere to a gluten-free diet. In patients who are symptomatic, we would also recommend that they be transiently lactose-free because they may develop a lactase deficiency as a result of villus atrophy. Well, we talked about wheat, barley, and rye, but this also extends to a wide variety of grains related to wheat, barley, and rye. Wheat bran, wheat starch, wheat germ, farro, triticale, matzo meal, gram flour, kamut, spelt. All right. I had patients saying, oh, we're not taking wheat, we're only taking spelt. Well, I'm sorry, spelt is a type of wheat. So you really have to educate your families as to what they must avoid. There are other sources of gluten. I put this one out really as sort of a joke. Make sure your patients, if they like particularly Asian food, to stay away from Kikkoman soy sauce. It contains wheat. La Choy and Tamari are the two commercial brands which do not contain wheat and which are gluten-free. Again, modified food starches, malt extract. Again, because of increased labeling that is now required by the FDA, and who knows what's going to be happening with our present administration, foods usually have to have a label saying whether or not they contain gluten or not. Not all do, but many more do than was indicated previously. The gluten-free grains and starches are shown here. We talked about buckwheat. Quinoa is another one. Again, there are brands of all of these grains which may say this is manufactured in a facility which also manufactures gluten-containing products. And we have to beware of cross-contamination in those situations, particularly oats, which are commonly processed in grain processing plants that produce other cereal grains. So you have to watch out for that. And then a whole variety of products that one has to consider. The treatment usually is associated with clinical improvement within 2 weeks. In children, within the first 2 years of life, usually by 1 year, they're achieving catch-up growth. I've never had to put a patient on steroids, but it's certainly been reported. And there are anecdotal reports of the use of immunosuppression in patients who are particularly refractory to therapy. Again, we talked about celiac disease being a proximal disorder, so folic acid supplementation is extremely important since folate is best absorbed in the proximal third of the duodenum. Generally, we recommend that patients with celiac, certainly early in the course of therapy, receive 1 milligram per day. Again, briefly, bone mass before and after a gluten-free diet is shown here. This is an interesting slide. This is the bone mass Z-score in controls. These are patients with classical celiac disease showing a negative Z-scores. These are 7 of 11 relatives with celiac patients who are asymptomatic, who also had below the waterline Z-scores. Again, the reason for screening relatives of patients. And again, very effective in improving the Z-score for bone mass. I'm not going to go through this. All of the fat-soluble vitamins should certainly be supplemented early in the course of disease, including vitamin E, vitamin D. We talked about folate, vitamin A. And as the mucosa repairs, one can withdraw from routine supplementation. Previous studies have shown that patients with celiac disease, independent of whether they are maintained on a gluten-free diet, may be at risk for a wide variety of other disorders or problems, including autoimmune diseases, osteoporosis, liver disease, and cancer. Small bowel cancers have been reported in increased frequency in patients with celiac. T-cell lymphomas particularly, as well as non-Hodgkin's lymphoma, have been increased. And some, but not all data, support adherence to a gluten-free diet as reducing the risk of cancer. So the future, again, the gluten-free diet remains the best treatment. We have to refine our understanding of gluten-free. The FDA has mandated better food labeling, and commercial institutions have finally recognized the value of producing gluten-free products. And with that, I'm on time for a change. So I've stopped sharing.